Hello friends, hope you are all doing well. Today our topic for discussion is investigation and management of postcoital bleeding. This article was published in 2022. It's a very beautiful article. They've explained very well everything. What are the causes of postcoital bleeding, history points, what are your differential diagnosis. So now we have to start with the postcoital bleeding. Postcoital bleeding is the commonest gynecological symptom, affect up to 9% of the women. So, what is postcoital bleeding? It is defined as non menstrual bleeding or spotting occurring immediately after sexual intercourse. The prevalence of postcoital bleeding in community range is 0.7 to 9% with an annual cumulative incidence of 6% in premenopausal women. So, although postcoital bleeding is considerable a cardinal symptom of cervical cancer, but its positive predictive value is very low. So, nevertheless, the principal aim of investigating women with postcoital bleeding is to exclude cervical cancer. So, how will you assess the woman with postcoital bleeding? So, how we assess? We assess through by we have to ask about her some history point. So, first of all, what are the causes of postcoital bleeding? The causes of postcoital bleeding are benign causes, urogenital atrophy. Those usually postmenopausal women present with postcoital bleeding. So the first diagnosis would be atrophic vaginitis, or in that the patient present with usually mild bleeding or spotting. So the first one is urogenital atrophy, benign vascular tumor of the genital tract, hemangioma, AV malformation. Usually AVL malformation in those having a reproductive age, premenopausal women. So you when they are presented with postcoital bleeding, so in mind you must have a differential of AV malformation. Cervical or endometrial polyp, cervical ectopia, and most common cervical endometriosis less likely. Infection, most common are the causes of postcoital bleeding are infection, vulvovaginitis secondary to candidiasis or trichomonas, cervicitis secondary to chlamydia, gonorrhea, endometritis, presence of intrauterine contraceptive device. Then vulval symptoms are vulvar dermatomes, lichen sclerosis, genital warts, genital ulcer, genital wart, genital ulcers, cervical cancer, endometrial cancer. Others are trauma and genital piercing, bleeding disorders, foreign body, sexual abuse, pregnancy related, and female genital mutilation. Usually, female genital mutilation are most common in Somalia and South Africa areas. So, what are the indications for referral to secondary care? Women presenting with symptom of cervical cancer, unexplained postcoital or persistent vaginal discharge, so we have to refer urgently into the within 2 weeks we have to refer to secondary care. So in UK they have a proper system. First of all, they have a local tertiary local hospital like BHU RHC. They have to decide whether to this patient we have to refer to tertiary hospital or not. Usually in our setups, sometimes the patient directly when the patient having postcoital bleeding, so they directly come to the tertiary hospital. Abnormal appearance to cervix or vaginal on speculum examination, so you have to refer it within 6 weeks to secondary care. So, what are the history points? History and examination to help elicit risk factor and signs suggestive of underlying pathology. So, what is the patient age? It will depend upon the patient age, the duration, frequency, and amount of bleeding, menstrual history, including normal bleeding pattern and last menstrual period, the presence of other gynecological symptoms such as vaginal discharge, pelvic pain, dyspareunia. So, in mind, you have a DDs of if vaginal discharge, pelvic pain, dyspareunia, DDs of cervical endometriosis, ectropion, or there may be infection. The presence of other contraceptive history, use of other hormonal therapy, for example HRT, tamoxifen, history of HPV. Usually as combined oral contraceptive, the patient may present with cervical ectropion because they will cause this hyperplasia of the cervix. So the other thing is HPV immunization. You have to ask about her because one of your DD in postcoital bleeding would be benign cervical disease or cervical carcinoma. So one of the station came as a structured discussion that patient present with postcoital bleeding or foul smelling vaginal discharge. So you have to ask to rule out all these causes. Then the examiner will provide you in. You have to ask the examiner examiner a certain investigation. So whatever she want, if the case going through the infection, so you have to treat the infection. If the examiner that on pap smear there is dyskaryosis, benign cervical condition, then you have to treat accordingly. So your first approach will be must that you have to ask about her history points. So from the start, your management will start from the history. So through history you have to rule out diagnosis. What is the definitive diagnosis? Depend upon the definitive diagnosis after investigation. Then for from history you will make a differential diagnosis. For definite diagnosis, obviously you do an examination and certain investigation for definitive diagnosis. So it is very important in every case you must know about the history points for every case. So the cervical history, including the date and result of last screening test, detail of any previous colposcopy and treatment, sexual history, any previous history of sexual transmitted infection, where appropriate, relevant past, because one of our diagnoses could be that is chlamydia, gonorrhea, and so we have to ask about the patient symptoms. Relevant past medical surgical history, including bleeding disorder and certain current medication, particularly use of anticoagulant. Other risk factors such as smoking status are also important. So a sexual risk assessment is particularly pertinent in women aged 25 years or younger in whom there is a high prevalence of chlamydia. The further guidance on this is available via BASH guidelines. All the patients should be screened for domestic and sexual abuse because trauma to the genital tract can result of postcoital bleeding. So this is one of the important points, that you have to rule up the sexual domestic violence, sexual abuse, and screen for these type of causes. Fear or embarrassment may mean that the women do not volunteer this information, so the question need to be asked the HARK question, HARK. So we have to see in that table that what questions include in HARK are a simple way to sensitivity inquire about the intimate part and wildness, specific guidance on identifying and responding to disclosure of domestic abuse and development by the Department of Social Care. So these are the certain points if you are suspecting that the patient has a suspecting case of domestic violence or sexual abuse. So you have to ask about these questions. So H for humiliation: have you been humiliated or emotionally abused in other way by your partner or ex-partner? Afraid: have you been afraid of your partner or ex-partner? So it is basically screen for intimate partner violence. Rape: have you been raped or forced to have any kind of sexual activity by your partner or ex-partner? Kick: have you been kicked, hit, snap, or otherwise physically hurt by your partner or ex-partner? So especially these type of question you have asked, especially in those that are in reproductive age or young girls presented with bleeding. So you have to exclude these type of causes like sexual abuse or any domestic violence or these type of things. Then we'll proceed toward the examination. Women presenting with postcoital bleeding should have abdominal examination and careful inspection of the vulval skin before proceeding toward the speculum examination, because one of the causes vulval dermatosis, lichen sclerosis, genital warts, and fall ulcer. You have to examine her vulva. Then you will proceed toward the a cusco speculum should be used to inspect the vaginal wall for atrophic changes, laceration, prolapse, or ulcerated region. Note that any vaginal discharge or presence of a foreign body with visual inspection of the cervix may identify a cervical ectopy or a polyp. Most invasive cancer caused postcoital bleeding are clinically apparent on vaginal examination. So findings suggestive of cervical cancer include ulceration, fibril tissue, contact bleeding, or craggy irregular mass. The examination should be excluded with a bimanual examination to palpate the cervical axis uterine size at initially to exclude cervical excitation clinical feature of PID. So these are the important clinical examination. The summary is that you have to do an abdominal examination to exclude whether if you are suspecting cancer, maybe you have some finding in abdominal examination. It may be that this cancer may spread to the other organ. So abdominal examination is must to exclude any mass or any palpable mass, or especially verbal examination local to look for any ulcer, genital ulcers, or any if you are suspecting warts. And then per speculum, cusco-specular examination, look for the if she's postmenopausal, to check for the vaginal skin, whether it is atrophied or not. Then you will clearly, thoroughly examine the cervix, its regularity and its contour, any mass, friable mass on the cervix. So these are the examination points. Then this is a beautiful algorithm that when the patient present with postcoital bleeding, you have to take her history, physical examination. Then first would be if they reproductive age, you have to do microbiological swab. If positive, treat infection and refer to genitourinary medicine for contact tracing. If cervical screening test, if overdue, then you have to do her cervical screening test. If abnormal test, then you have to refer for colposcopy. So if you are suspecting clinically abnormal cervix, then you have to direct to colposcopy. For example, if you find any mass on the cervix, so you will not do the cervical screening test, because in naked eye, when you find something mass, if you are suspecting polyp, then you can take pap smear. But if there is a friable, irregular mass, fungating mass, it means the one of the first differential over your mind, it is could be a cervical cancer. So in that case, you will do direct colposcopy. But if you are suspecting that the cervix is, there is a cervicitis, inflamed cervix, cervical ectopy, there is a small cyst on the cervix, then you can do pap cervical screening test and pap smear. The normal cervix but persistent postcoital or coexisting intermenstrual bleeding, so consider TVS, papal biopsy or hysteroscopy. So maybe if postcoital or intermenstrual bleeding, so you have to do a hysteroscopy. So one of the differential could be endometrial, there may be endometrial polyp associated with it. So you have to do then transvaginal ultrasound to check for endometrial polyp, endometrial hyperplasia. So two diseases can be coincided with each other. Then what is initial investigation? So as depend upon the cause, if you are your differential, what are your differential, then according to that you advise investigation. So it is important to exclude pregnancy in women of reproductive age presented with abnormal bleeding. Then cervicitis secondary to chlamydia infection is a common cause of postcoital bleeding in a young woman. So cervicitis is the secondary to chlamydia is common cause of postcoital. Thus, vulvovaginal swab should be taken for NAT and those as a risk of infection. So one of your SBA came that especially if you are suspecting infection, there may be controversies regarding that we will take vulvovaginal swab, high vaginal swab or what. So in both BASH guidelines and as you can see that the first, if they have given you multiple choices that you will take vulvovaginal swab, high vaginal swab or lower vaginal swab, then the correct answer would be vulvovaginal swab. For in chlamydia, we'll do nuclear amplification test. So in that SBA, you have to clear in mind that the answer would be vulvovaginal swab. Don't confuse with that, because some mentors say it is high vaginal swab, some say that vulvovaginal swab. So it is clear cut in both BASH guidelines and in also already in this talk article that vulvovaginal swab you have to taken for chlamydia or gonorrhea for NAT testing. And those at risk of infection, if gonorrhea is suspected, an endocervical swab for antimicrobial sensitivity testing should be taken in addition to vulvovaginal swab. So if you are suspecting gonorrhea, then they say that you have to take an endocervical swab for in addition to vulvovaginal swab. So you have to take both the swab, vulvovaginal swab along with endocervical swab. So these are two differentiating points. So note that in which case what will you do. So these tests do not need to be repeated if they have already completed in primary care. A cervical screening test can be taken if the patient age is 24 years old. So in PAP screening test, we will start from 24 years of age. If it's about 25, if it have not been done, so you have to do cervical screening test. This is a screening test rather than a diagnostic test. It is appropriate in patient with a suspicious cervix on examination. These women require urgent colposcopic assessment. Really, endometrial pathology can be seen with postcoital bleeding. If the cervix is clinically abnormal, consider a TVS, papal endometrial sampling, or outpatient hysteroscopy to exclude endometrial pathology, especially in women with coexisting intermenstrual bleeding. One advantage of the diagnostic hysteroscopy is ability to visualize the endocervical canal. However, this procedure is usually reserved for women with irregular or thick endometrium on scan or with persistent symptom in absence of pathology. So this, if you have only read this the causes and the history points and the table, this is enough for you once you have make a history points and then make a notes of this. So this one is enough, so you have to not read again this TOG article. So make a points tabulated points of this and note it, so it will helpful in both for SBS and for TOEICs, because when you have to clear the exam, then obviously you have to give the TOEICs exam. So इसके लिए आपको क्या करना है कि आपने इसके नोट्स बनाने हैं. सो आपके लिए बहुत हेल्पफुल होगा बोथ फॉर एग्ज़ाम्स, फॉर थ्योरी और टॉक्स के लिए. तो आप प्रिपरेशन इस तरह करें कि आपके लिए दोनों चीज़ें आपके लिए आसान हो, ठीक है. क्योंकि अगर आप एक के लिए करेंगे कि जो बस एज MCQ रिलेटेड आपने पढ़ लिया, सो दैट विल नॉट एनफ, क्योंकि ये चीज़ें टॉक्स में भी आती हैं, ठीक है. सो इम्पॉर्टेंट चीज़ें अपने लिए पॉइंट्स नोट करें ताकि अभी से आपकी फॉर प्रिपरेशन फॉर बोथ हो, थ्योरी और ऑस की स्टेशन के लिए. So then they say that when is the referral for colposcopy is indicated. So the National Cervical Screening Program has now introduced HPV primary screening testing in England, Scotland and Wales. If high-risk HPV is detected, cytology will then be performed to be checked for abnormal cells. Women require onward referral to colposcopy if they are found to have abnormal cytology, including borderline changes, low-grade dyskaryosis, high-grade dyskaryosis, possible invasive cancer of granulal changes. So now they have changed the recently that HPV testing is added in this protocol. So when the HPV test is positive, then you have to do cytology. If the cytology is low grade, high grade, then you refer the patient for colposcopy. Women also require colposcopy if they have two sequential inadequate test or the cervix cannot be identified on speculum examination. So if they have two inadequate tests and the cervix cannot be identified in speculum, then we have to do colposcopy. So this point is also important. Mark that point. In context of postcoital bleeding, women require a colposcopic assessment within 2 weeks of the appearance of the cervix is suspicious on examination. The NHS cervical screening program adequates women with persistent postcoital or vaginal discharge in the absence of other pathology to be referred for examination by a gynecologist experienced in the management of cervical disease. Gynecologists may refer them for symptomatic colposcopic examination outside the cervical screening program if the cancer is suspected. So, if the patient presented with persistent vaginal discharge, refer her for gynecological experience to do her colposcopy. Then what is the management? So different causes have different management. We will discuss in that. A cervical ectropion is a normal physiological cervical eversion result in friable mucus secreting glandular epithelium of the endocervix being exposed on the ectocervix. It classically appears as a red disc around the external os. It is often after menarche, during pregnancy, and in women taking the COCP. So these are three causes of cervical ectropion. That is during pregnancy, those are taking COCPs. So as a result of cervical remodeling in response to estrogen, exposure to vaginal milius eventually transform the glandular epithelium into squamous epithelium is a process called squamous metaplasia. So the exposed columnar epithelium is suspected to trauma and contact bleeding during. So because all the internal epithelium is the columnar epithelium also become in metaplasia occur because internal columnar epithelium and outerly the squamous epithelium. So the internal all when it is hypertrophy, there is hyperplasia. So all the cells coming out of from the internal endocervix. So when there is a contact, so when the contact of anything, so it will lead to bleeding. So the exposed columnar epithelium is susceptible to trauma and contact bleeding during intercourse or examination. Women with cervical ectopy may present with increased mucobrillial vaginal discharge and postcoital bleeding or may be asymptomatic. On speculum examination, a cervical ectropion may cause contact bleeding, make it difficult to exclude significant disease without colposcopy referral. Women should be informed the physiological nature of this condition. Give this reassurance. The patient may decide not to have further treatment. If applicable, changing the COCPs to the progesterone only pill may resolve the symptoms. So in history, you have also asked about if the patient is taking COCPs, it could lead to a cervical atrophy. So you have to stop that and change into POPs. Women with persistent or troublesome symptom may offer cryotherapy or diathermy to the cervix, because some are offended with that repeated vaginal discharge, so they may fed of these. So in these cases you can also offer diathermy or cryocotry to the cervix. However, the risk of recurrence should be highlighted, especially in the contents of exogenous hormone. So in addition, women should be informed of potential side effects to the treatment, include copious vaginal discharge until healing is complete and cervical stenosis. So initially you have to prescribe a mild ectopy, so you have prescribed in some cases cervicitis that lead that along with the cervical ectopy, so you have to prescribe antibiotic if it is not working and still persistent discharge, then you will offer her cautery or the diathermy. So you have also tell the patient that if the exogenous hormones she can take continuously, then the symptoms may recur. If the woman has a regular and negative cervical screening and the doctor is satisfied with the diagnosis of an ectopia, the cautery should be performed in gynecological clinic. If it is a doubt, a cervical biopsy should be performed and treatment delay under the histology of no. If the clinician is confirmed and would confirm that this is a cervical ectopy, no need of screening, so she may continue with the cautery. But once you have cauterized, so you may not take the pap smear because you have cautery all that area. So before that, if you are in suspicious, better to go for initially pap smear, then do cautery, so that maybe later on she may need other procedure. Cervical polyp are usually asymptomatic and found incidentally on speculum examination, but can also present with bleeding after intercourse. So in some patients presented with persistent postcoital bleeding, and I have seen so many patients that in periphery they prescribe COCPs or POPs, but still the bleeding is same. When you do a speculum examination, then a big polyp, cervical polyp coming out through the cervix. So you have to do in clinical practice, in once the patient present with any type of bleeding, vaginal bleeding, postcoital bleeding, intermenstrual bleeding, so examination is must. You find something during examination. If it is inconclusive, then obviously do ultrasound. On examination, they appear as a pedunculated fleshy lobular structure, can arise from the endocervix canal, ectocervix, or from an endometrial polyp prolapsing to the cervical canal. They are friable and easily bleed on contact. Polyp are thought to be arise from chronic inflammation or after an atypical response to hormonal stimulation. The most frequently present in perimenopausal and postmenopausal women, symptomatic polyp NCs with coexisting abnormal cytology should be removed and sent for histological examination to exclude malignancy. The most cervical polyp measure less than a few centimeters in diameter can be avulsed during speculum examination. Depend upon the stalk, अगर पतला stalk है तो आप उसी time निकाल सकते हैं. The polyp should be grass space using polyp forceps to twist it off. Hemostasis can usually achieve with silver nitrate. Large or broad base polyp may require removal with loop diaphthermy or colposcopy. Symptomatic cervical polyp can be associated with endometrial polyp and hyperplasia, particularly in perimenopausal and postmenopausal. So, endometrial abnormality are reported up to 55% of the postmenopausal women with cervical polyp. So, this is one of the SPA from Mrcog book, that endometrial abnormality is reported up to 55% of the women with cervical polyp, advocating that these women should be offered hysteroscopy and endometrial sampling. In addition, avulsion of the polyp, the risk of dysplasia or malignancy in cervical polyp is estimated to be 0.0 to 1.7%. The next one is cervicitis and endometritis, PID. So if the STIs and chlamydia is the commonest bacterial STI, affects 70% of the women under the age of 35. Risk factors for infection include age under 25, a new sexual partner, more than one sexual partner in the preceding year. So you have to ask in history that history of multiple sexual partner, especially also in postcoital bleeding. Inconsistent use, because in cervical cancer, multiple sexual partners can lead to cervical SIA and infection, and also in infection. So infection and in postcoital bleeding, you have to ask about her multiple sexual partners. Chlamydia can be detected using NAT either from vulvovaginal swab or urine. First treatment for women with suspected or confirmed chlamydia infection is azithromycin 1 gram orally, single dose, followed by 500 mg daily for 2 days, or doxycycline 100 mg twice a day for 7 days. So single treatment with better compliance, women should be advised to abstain for intercourse until treatment is complete and should be referred on to a local sexual health. So for screening for other STI, and partner notification is very important in STIs. Test of care is not required unless there are compliance issue or the patient is pregnant. So, like chlamydia, it is best detected using NAT or vaginal swab. First line treatment of uncomplicated gonorrhea, ceftriaxone 1 gram intramuscularly as single dose. So in chlamydia, we will give both doxycycline, or can be given azithromycin 1 gram, or doxycycline can be given. So with the gonorrhea, doxycycline cannot be prescribed because increase resistance with that. So in gonorrhea, you have to choose the first line treatment in uncomplicated gonorrhea is ceftriaxone 1 gram IM as a single dose. Test of these two are SBAs, that in chlamydia what you have to give, and in gonorrhea what type of treatment you will give. Test of cure is advised for all confirmed cases of gonorrhea because of the increased prevalence of antibiotic resistance strain. So I've told you that in gonorrhea there is increased resistance. So in chlamydia you will not have to do a test of cure, but in gonorrhea you have to do a test of cure because there increased resistance to certain strains. All women who are test positive for gonorrhea should be referred on to local sexual health service for further testing and partner notification. If endometritis or PID is suspected, broad-spectrum antibiotic should be commenced without delay. So in that case, if you are suspecting delay, so you will admit the patient and you will start her on IV antibiotic. Microbiological swabs should be ideally obtained before commencing antibiotic therapy. Long-term complication of untreated PID, pelvic pain, addition, ectopic pregnancy, and subfertility. Antibiotic regime by aim to ensure all the potential causing microbes include gonorrhea, chlamydia, and anaerobes. If the patient is clinically unwell, they will require inpatient admission with IV antibiotic. And then we have a cervical cancer. So in cervical cancer, the prevalence of SIN and cancer among women with postcoital bleeding estimated to 3 to 18%. So this is the different study have been done. So this paragraph they said women called every 3 yearly until the age of currently all women aged 25 to 64 years are routinely invited for cervical screening. Women are recalled every 3 years until the age of 50, when the screening interval increases up to every 5 years. Screening invitation cease after the age 65 unless the women have previously had cervical abnormality or positive HPV test. These women should continue to be recalled until they have completed follow-up. HIV positive are at high risk of developing cervical dysplasia or invasive cancer owing to immunosuppression, therefore required annual screening. So, and one of SB came that in HIV patient, if because they are high risk of developing cervical dysplasia or invasive cancer, so in these cases you will do annual screening. Otherwise, we will a normal screening protocol that up to 25 to 50 years every 3 yearly, then 50 to up to less than 65 every 5 yearly. And then if you are if the patient having HIV positive, then you will do annual screening. So this is one of the SBA. High-risk HPV are account for nearly all cervicals. HPV 16 and 18 are the commonest pathogen, accounting for over 70% of the cervical cancer. And it is estimated that 70% of the women with contract HPV in their lifetime. Most will be clear of the infection. However, persistent HPV DNA can lead to development of dysplasia and invasive cancer. So if in that cases when counseling, counseling may be usually the favorite topic of the RCU, the CPSP, basically the cervical screening or benign cervical condition. So usually these type of station also come in counseling as a counseling. So you have to tell the patient whatever, whether she's not vaccinated. In vaccination history is also very important. So in that case, you will also tell that every 70% of the women have HPV in in their lifetime. So usually in most of the cases they will clear it by self, but in some cases they lead to invasive disease like the low grade dyskaryosis, high benign cervical condition may occur. So in counseling you have to tell the patient that in every woman encountered these HPV the infection. Then after that, specifically in those patient, sometimes the patient came that I've already vaccinated. A scenario like this type of also come that I'm already vaccinated. Why this type of cervical condition, benign cervical condition, have been occur in me especially. So you have to tell the patient that there are different strains. Usually the vaccination is not a proper cure of this condition. So there may a thousand of strains of HPV. Maybe you can see there are some the vaccine are specifically for some strain. Maybe that HPV you are protected, but the other strain can cause cervical cancer. So in counseling, these type of answers you have to given to this patient, and give her that knowledge about the regarding what type of question they have asked from you. It is essential that 70% though, however, persistent HPV can lead to development of dysplasia and invasive cancer. The causal association between HPV and cervical cancer lead to introduction of HPV vaccination program in 2008 with aim to prevent the acquisition of HPV infection. The current immunization program compares 2 doses of Gardasil and quadrivalent HPV vaccine which protect against HPV 6, 11, 16 and 18. So in Gardasil, there will be 2 doses, and the quadrivalent, which 2 doses of Gardasil or quadrivalent HPV vaccine, which protect against HPV 6, 11, 16, and 18. The program initially targeted 12 and 13-year-old girls, but since have been extended to include boys of the same age. So you have to give this type of vaccination to the boys also. They included in that. Indication for colposcopy we discussed earlier in this review. Women with low-grade lesions in one can be offered surveillance with further screening in 12 months, and on other hand, women with lesion consistent with high grade sin 2 sin 3 should be offered excisional treatment as a first visit. Excisional treatment associated with twofold relative increase the risk of preterm birth, but absolute risk remain low. Women with invasive should be referred to tertiary center for further assessment and management. So later on, this separate lecture for the low grade or high grade lesion. So we will discuss in that in detail. But you have a bit knowledge about that what is cervical cancer, what are the HPV types, and what type of vaccination we have to give to this type of patient. Vulval and vaginal lesion. Urogenital atrophy results from estrogen deficiency and commonest in postmenopausal women. It is typically present with vulvovaginal dryness, irritation, decreased lubrication, superficial dyspareunia, and occasionally postcoital bleeding secondary to trauma during intercourse. Examination finding consists with vaginal atrophy, including pale, dry vaginal mucosa with contact bleeding on the vaginal wall or cervix. Treatment include the use of vaginal moisturizer, lubricated topical estrogen, dihydroepiandrosterone, osfemin, and laser. Vaginal dermatosis such as lichen sclerosis, lichen planus, contact dermatitis may cause postcoital bleeding associated with fissuring of the skin. Patient with these conditions should be advised to avoid soap and potential irritant. Regular use of emollients and topical steroids reduce inflammation and improve skin integrity. Vulval biopsy should be considered if there are pigmented lesion, ulcerated or eroded. So if you are suspecting vulvar dermatosis lichen planus, sclerosis, and so in that case you will first of all you will advise the journal advise soaps, irritant that cause may aggravate the symptoms, and also you have to start her on steroid. Topically steroid is very helpful in these cases. Then lichen sclerosis is associated 4 to 7.5 risk of developing squamous carcinoma and required annual. So this is one of the SBA that which type of benign condition of vulva that lead to squamous cell carcinoma of the vulva. So that is lichen sclerosis. Lichen sclerosis 4 to 6% lead to risk of squamous cell carcinoma of the vulva. Vulval intraepithelial neoplasia and vulval cancer typically present with vulval irritation and palpable lesion but may also cause unscheduled bleeding. These lesions may present as a thickened white or pigmented mucosal plaques, warty lesion, or a persistent ulcer and may be unifocal or diffuse. So, lesion should be biopsied rather than excised and should be include the area of epithelium when there is transition of normal to abnormal tissue. So, in some time you will suspect that the lesion is abnormal, then you have to take a biopsy. If you are confirmed that it is a warts or there may be due to irritation, vulvovaginal candidiasis, then you have to not take the biopsy. But in specific cases like if you are suspecting vulvar intraepithelial neoplasia and abnormal lesion, then you have to take a biopsy. But if you are suspecting that is lichen sclerosis, lichen planus, because in lichen sclerosis or planus there will be a white plaques or hyperkeratosis. So in that condition, you have to start initially treatment. But you have find on examination an ulcer, and if you exclude that this is not a herpes, exclude that it is not a herpes or not any other genital ulcers that is invasive. So in that, if you are suspecting that is it could be an invasive lesion, then you have to take a biopsy of that. So include so if you are taking biopsy, you have to take both the normal abnormal and normal epithelium. So if you have to take the normal tissue as well for biopsy. If vulvar cancer is strongly suspected on examination, urgent referral to tertiary care should be not be delayed until awaiting the biopsy result. Rarely, postcoital bleeding may presenting symptom for other cancers of female genital tract, vein, vaginal intraepithelial neoplasia, and vaginal cancer are usually asymptomatic. But most women report spotting following intercourse and usual vaginal discharge. Vein appear as a white or red mucosal plaques, whereas vaginal cancer present at persistent ulcer region, usually on the posterior surface of the upper part of the vagina. Women with suspected van or vaginal cancer should be urgently referred to colposcopy or further assessment and biopsy. So van is usually associated with cervical carcinoma. Most likely, sometime the patient may have a cervical lesion along with that, or sometime that the cervix lesion extended to the vagina. So you have to exclude that whether it is a cervical or it is a vaginal carcinoma. So for that, that whether it is a vaginal or it is a cervical carcinoma. So vaginal usually carcinoma in those patients present in older ages, but cervical carcinoma they present in early stages and they must have a benign stage before they proceed to the invasive stage. So you have to differentiate between these two, that in vaginal cancer they usually present late and mostly in postmenopausal women, but in that cervical cancer in reproductive age. Finally, postcoital bleeding may occur following trauma to the lower genital tract such as vaginal laceration. So studies some kind of vaginal trauma during consensual intercourse. In case of traumatic bleeding, surgical repair is the standard care. So approximately 50% of the women present to the primary care will no obvious underlying cause. The woman should be reassured that 60% of the women experience a spontaneous resolve of the symptoms within 6 months. So this is the whole. Then this is the recommended antibiotic for PID. So that this type of this table, and also the same treatment also given in BASH guidelines, that what are the outpatient treatment and what are the inpatient specifically in PID. So outpatient IM ceftriaxone single dose doxycycline or metronidazole for if the patient is stable, and if the patient or oral ufloxacin 500 mg twice a day for 14 days, oral metronidazole and oral moxifloxacin. And inpatient, if the patient is not very symptomatic and in severe pain, fever cannot be controlled, then inpatient treatment. So IV antibiotic in the form of, so you have to admit the patient and start her on IV antibiotic if you are suspecting pelvic inflammatory disease. So this was the whole lecture. Hope you find it good. And if you have any queries, kindly comment on this that lecture. And also you can WhatsApp on group for any queries. Thank you so much.